Hello, everyone. My name is Jim Seberg, and I'm the Assistant Director of the Medical Cannabis Research Center at Drexel University. Today, we're happy to be joined by two co-investigators on the MCRC's patient registry study, Dr. Katya Federova and Janna Ataiants, both of whom are also senior research scientists at the Dornsife School of Public Health, and they also both graduated from the Dornsife School of Public Health with their DrPH degrees. In addition to being co-investigators on the MCRC's patient registry study, Dr. Ataiants and Dr. Federova have also been working on a NIDA-funded cohort study of young adults and cannabis users in Los Angeles titled Cannabis Health in Young Adults, or CAYA for short. Today, Dr. Federova will be presenting on her manuscript titled Terpene and Cannabinoid Profile Preferences and Cannabis Use Practices in Medical Cannabis Patients Who Use Cannabis for Anxiety and Pain. She will be then followed by Dr. Ataiants, who will be presenting on her new manuscript titled Assessing Anxiety Longitudinally Among Medical Cannabis Patients in Pennsylvania. Before I pass it over to Katya, I wanted to highlight some similarities and differences between the studies. While both studies are based on our patient registry study, which is a longitudinal questionnaire for patients to answer every 3 months, and both also analyze anxiety. There are some key differences. Katya's paper is cross-sectional research, meaning that it examines a point in time, while Janna's paper is longitudinal, meaning that the same outcome is measured over several points of time and then compared. Plus, while Janna's research is solely focused on changes in anxiety associated with more general medical cannabis use, Katya's research is primarily centered around pain, which can be comorbid with anxiety. And Katya is specifically looking into the analgesic and anxiolytic effects of terpenes, which are naturally occurring compounds within cannabis. So I'll pass it over to Katya now, who will be sharing her presentation.
Hello, everyone. So I first would like to start with the funding source. This study was funded by a multi-year research agreement between Drexel University and Agronomed Biologics, which is owned by Verano and multi-state cannabis company. And this research partnership between Drexel and Agronomed was approved by the Pennsylvania Department of Health upon the medical cannabis legislation was signed into law in 2016. A little bit of background. You might all know that pain and anxiety are two most common and frequently co-occurring qualifying conditions among medical cannabis patients in Pennsylvania. While major cannabinoid effects like THC or CBD are well documented, there is a little research on the therapeutic potential of terpenes. And what terpenes are generally aromatic substances, aromatic constituents in cannabis and other plants that might have some properties that might affect anxiety and pain symptoms, really specifically how it relates to our analysis. So like here is the list most common terpenes and their associated aroma. So for instance, caryophyllene has a peppery aroma and it's well known for its anti-inflammatory properties. Myrcene, with its fruity and earthy aroma, has effects both on pain and anxiety symptoms relief. Linalool, well known, like lavender essential oils, many people use it for kind of reducing anxiety, for calming down, especially when you wind down before like sleep. Terpenoline, this is the most controversial one. This one has fruity, spicy aroma. And while there is pretty consistent evidence on it being like it having anti-inflammatory properties, but effects on anxiety is not consistent across animal and human studies. In animal studies, we see it's being sedative. While in human studies, there is a potential for anxiogenic effects, potentially due to the animal studies are frequently using isolates, not like the whole cannabis plants, while human studies were referring here to they're kind of looking at the whole cannabis plant, and rush effect might be responsible for differential impacts of terpenoline on anxiety. This is what I just mentioned, like the difference between isolates and animal and human studies. The very good point here, like while Pennsylvania is well suited for this type of research, specifically looking at the terpene and cannabinoid profile and how it might impact cannabis anxiety and pain, is because PA medical cannabis program requires extensive phytochemical laboratory testing. So you might not see it in many other states that products are labeled with exact percentage for key terpenes and cannabinoids. Cannabinoids is like common practice, but terpene is like rarely seen. In this analysis, we aim to answer two research questions, specifically to look into how generally cannabis practices and cannabinoid and terpene profile preferences differ between patients who use cannabis for anxiety only, pain only, or for both pain and anxiety. So in this analysis, we utilized over 500 quantitative surveys, and these results will be updated with their more recent data, because right now we are over 1,000 baseline surveys, so like it will be doubled, and our estimates hopefully will be more stable. So primary enrollment criteria to the cohort this analysis was based on was being a current medical cannabis patients living in Pennsylvania, patronized and lead dispensary, and being 18 years or older. We controlled for key demographic variables, our regressions. Those are classic ones like age, gender, race, ethnicity, education, income, and living with children. Our predictor was groupings by reasons for cannabis use, whether it was use of cannabis for anxiety only, or pain and anxiety. And our outcomes were cannabis forms, CBD use, microdosing with cannabis, frequency of use, specifically how many days of the past 90 days patients use cannabis, amount of cannabis per week in grams, and time of the day patients typically use cannabis, whether it was typically in the morning only, in the evenings only, in the middle of the day, or any time of the day. And finally, the second set of the outcomes was cannabinoid and terpene preferences. So like I said, our sample was divided into three groups: patients who use cannabis for pain relief only. Second group was patients who use cannabis for anxiety relief only. And the last group was patients who use cannabis for both pain and anxiety. And we examined the differences in cannabis practices and cannabinoid and terpene preferences with regression models adjusted for key significant demographic covariates. Just to corroborate our groupings, we looked at the pain and anxiety as a qualifying conditions, and whether a patient reported pain today, and the generalized anxiety disorder scale scores. And we see that proportion of patients with pain was largely concentrated within pain only and pain anxiety groups. And they're also like pain today was more likely to be reported by pain groups. And similarly, anxiety as a qualifying conditions was more prevalent among pain, anxiety, and anxiety groups. And respectively, GAT-7 or generalized anxiety disorder scores were higher among anxiety groups, pain, anxiety, and anxiety only. In terms of demographics, we see older patients within pain-only group, and we see greater proportion of males and non-Hispanic African Americans among pain-only group. No statistically significant differences were observed for other demographic variables. In terms of cannabis practices, we see a higher use of moon rocks and caviar and Rick Simpson oil among pain and anxiety group. And just to mention, moon rocks and caviar and Rick Simpson oil are kind of a concentrated forms of cannabis. And also we see greater use of topicals and creams by pain groups, pain only and pain anxiety. Pain and anxiety group reported higher CBD use, which was also prevalent among pain only group. Days of use were like the highest among pain and anxiety group, and also pain and anxiety group were more likely to use cannabis any time of the day, as opposed to limited to a specific time of the day, morning, end of the day, midday. Surprisingly, only 43% of the total sample said that cannabinoid profile influenced their strain of choice. And those differences were more pronounced among pain and anxiety group, or like where their choice of the products, cannabis products, was more influenced by cannabinoid profile. Surprisingly, not CBD, not THC factored into the selection of cannabis products. Like there was no differences observed for THC and CBD, but we do see that CBG was more preferred by pain and anxiety group. And another surprise that terpene profile was actually more important to patients in our studies compared to cannabinoid profile. And pain and anxiety group had greater, they kind of stressed more importance to a terpene profile as compared to anxiety only group, for instance. And what terpenes they looked for? Pain and anxiety group and pain only group had higher preference for myrcene. Pain groups also had a greater preference for caryophyllene, and we see the lower preference for terpinolene by anxiety group, anxiety only and pain and anxiety. And our findings should be considered in the light of several limitations. First of all, since it's a self-report data, we should also always remember about recall bias, especially when we talk about frequency of use. It can be, it can never be exact science. It's approximation. Also, in this specific analysis, we used cross-sectional data, so we cannot make any causal inferences from this data. And it might have limited generalizability, so our finding might not be applicable to other states, while they can inform research in other states. We have different policies, we have different patients populations, we have different products and requirements among products on medical cannabis market. And to conclude and summarize our findings, we see that we observe greater intensity of cannabis use by patients in pain and anxiety group, which could be potentially due to a greater symptom burden, as opposed to who use cannabis for pain only or anxiety only. CBG was the only significant cannabinoid that factored in the selection of cannabis products by patients who use cannabis for pain and anxiety, not THC or CBD. And in line with the previous research, caryophyllene was preferred by patients who use cannabis for pain, while myrcene was top preferred terpene among patients who use cannabis for pain only and pain and anxiety. Proportionally lower preferences for terpinolene among patients who use cannabis for anxiety and pain and anxiety, might suggest negative experiences or awareness of potentially anxiogenic effect of this terpene, which adds to the emerging evidence that needs to be further investigated in control studies. And finally, qualitative studies could provide context of the observed relationship in decision-making process when selected a specific product for anxiety or pain symptom relief. And actually, the last point was incorporated in the actual manuscript. We are in the process of submitting to the peer-reviewed journal. So qualitative findings are generally support quantitative data, and we just see like how like dispensary agents, like they do a really good job in specifically in Pennsylvania and Zenleaf dispensary, specifically on educated patients about terpene profiles and like their therapeutic properties. So like patients are like if we compare Los Angeles and Pennsylvania, patients in Pennsylvania are much better educated about these specifics. And this will be pretty much it on the analysis. And I just want to say huge thanks to the whole team who helped and supported this research, and more specifically to scientific and community advisory boards, and most importantly, medical cannabis patients who provided the data and insights so we can do a better job. And thank you so much for listening, and I will pass it over to Janna.
Okay, so yes, this is a longitudinal study of anxiety among medical cannabis patients in our study. So like I have the same kind of disclosure of funding. The study was funded by Agronomed Biologics, owned by Verana. And this is some background of many United States jurisdictions which legalized medical cannabis. Only several, including Pennsylvania, allow anxiety disorders to be a qualifying condition for medical cannabis. And partially the explanation of this is that there is limited clinical evidence on efficacy of cannabis as an anxiolytic agent. But like as a very minimum, it's known then that any dose of CBD and low doses of THC may help reduce anxiety symptoms. However, people commonly self-medicate with cannabis for anxiety. And there is like few clinical trials related to anxiety, and basically there is like not a lot of observational studies on longitudinal outcomes of anxiety. So basically what we have is some studies from UK, which shows short and medium term improvements in anxiety among medical cannabis patients. We have some studies from Canada. The reports are mixed. So some studies show improvement, some studies show no change. And in the United States, we only have one study, actually based in Pennsylvania, which shows that in 3 months, there is a reduction in anxiety among medical cannabis patients. And basically, this is it among medical cannabis patients. So we would like to fill this gap. And not only like to measure anxiety on average, but also to do something else. Previous research examined observed groups. They compared anxiety based on, for example, in medical users of cannabis versus recreational users, or among people who use cannabis for anxiety purposes versus those who do not use cannabis for anxiety. However, what if anxiety itself kind of divides people in latent groups, in unobserved groups. And what if people in those groups, they have like, similar patterns of change over time? So basically the question is, are there unobserved latent anxiety groups among medical cannabis patients? So therefore, the study tried to answer 3 research questions. First of all, first question is, can we identify latent group of patients based on their distinct trajectories of anxiety? The second question is membership in those trajectories associated with certain socio-demographic and health characteristics? So, like, in other words, are people with certain kind of demographics more likely to be in one anxiety profile versus the other? And finally, how did health and cannabis use outcomes change across those latent anxiety trajectories? So 3 research questions. We used data from our longitudinal patient registry study. We had 741 patients from June 2021 to October 2023. However, for this study, we decided to take into the analytical sample people with on whom we have observation over 12-month period, and not everybody, but basically if we have observation at least on three waves from baseline to month 12. So as a result, out of this like big sample, 741, we only had a subsample of 362 people who completed at least like 3 out of 5 waves of observation. And each wave is like, was done quarterly, every 3 months. We measured anxiety using generalized anxiety disorder 7 scale, which is like a validated scale. And it has like 4 categories: minimal anxiety, mild, moderate, and severe. And basically, also it's important that if there is like 4-point reduction in either like direction, it means a clinically important change, because there is like kind of statistical change and there is clinical change. And these methods we used, so basically to identify anxiety trajectories, we use growth mixture modeling. We used baseline characteristics like social demographics and baseline health as predictors of those trajectories using logistic regression. And we also used trajectory analysis to basically model how concurrent health-related and cannabis use characteristics change along with anxiety trajectories. So, question number 1, can we identify distinct trajectories of anxiety in our sample? Yes. So basically, the short answer is yes. We identified 2 trajectories of anxiety in the sample. Like the majority of people, kind of 2/3, they followed the mild anxiety trajectory. So basically they started with like mild anxiety and it statistically decreased over time. So they have a like negative and statistically significant slope. And approximately 1/3 of our patients, they started in moderate anxiety category and they kind of finished in the same category over 12 months. So we named the first trajectory mild anxiety and the second moderate. And if we would just change average, evaluate average changes in anxiety in the total sample, we would get just something in between. However, these are like two very, very distinct trajectories of anxiety. And if you would like to remember one thing about this presentation, this is your slide, how our sample is divided into anxiety trajectories over time, over 12 months. Question number 2 is membership in those trajectories is associated with certain characteristics. Yes, we tested several potential predictors of anxiety trajectories, and basically we found that females, younger people who were diagnosed with PTSD during their lifetime, and people who had anxiety disorders as a primary qualifying condition to enter Pennsylvania medical cannabis program, yes, they were more likely to be in this trajectory with more like severe level of anxiety. They're more likely to be in the moderate anxiety trajectory. Okay, and we also, as you see, we also tested something else. We tested chronic pain. We tested PTSD as a primary qualifying condition versus lifetime diagnosis. So those were not significant. Okay, and finally, our third question. So, okay, people have anxiety, but most likely, what if along with anxiety, they also have some concurrent adverse or not adverse outcomes related to their health or cannabis use? So basically, we tested several health-related characteristics, depression, because depression usually goes hand by hand with anxiety, health-related quality of life, prescription of CCRIs, and a prescription for benzodiazepines, commonly used anti-anxiety medications. And basically what we found is that something which is probably not very surprising, that people who are in this like moderate anxiety trajectory, they have also they had high level of depression from the start, and their level of depression increased over time. They had high level of anxiety interference with their daily life and high level of interference of depression with daily life, at least at baseline. And they had lower quality of life, lower health-related quality of life. And this is just an example. This is how depression symptoms look across this like anxiety trajectory. So basically, depression kind of mirrors anxiety trajectories, kind of the same trajectories as anxiety. And this is kind of summary. So over time, moderate anxiety, mild anxiety group exhibited like moderate to increasing and mild to decreasing levels of depression. And moderate anxiety group reported greater interference of anxiety depression with daily life and lower health-related quality of life. And but what is interesting is that despite divergent trajectories of anxiety, levels of medication use for anxiety was not kind of different. It was comparable between groups. Okay, now let's review how cannabis use practices change across anxiety trajectories. So there was no basically difference, at least statistical difference, in the frequency or intensity of cannabis use between the groups. However, moderate anxiety trajectory had higher level of CBD product use in the past 90 days. And also moderate anxiety trajectory, people in that group had higher level of problematic cannabis use in the past 90 days. At the same time, as you see here, the level of CBD product use was not kind of very high. And this is despite clinical evidence, right, that CBD kind of can reduce anxiety among people with anxiety. If you look in the right side of this table, you will see that probability of CBD product use was kind of 31 in moderate anxiety trajectory and 18. So basically it's 31% in moderate anxiety trajectory and 18% in mild anxiety. So CBD use CBD was not popular, was not common in our sample, and it reduced over time. Okay, so there are some limitations of this study. Basically, we included people with varying number of assessments from 3 to 5 due to attrition and rolling cohort design. All data are self-reports, and 12 months is still a short time frame. And our findings may not be generalizable beyond contexts with legal medical cannabis. Still, major conclusions. Medical cannabis use didn't increase anxiety in this sample as measured by GAD-7. Yes, our mild anxiety trajectory, the level of anxiety was significantly reduced. However, in neither of the groups, there was 4-point deduction in anxiety or 4-point increase in anxiety over 12 months. So basically, there was no clinically meaningful changes in anxiety. However, consistent elevated levels of anxiety was associated with consistent elevated level of depression and decline in health-related quality of life. So the conclusion is that we need more understanding of whether anxiety and comorbid depression are secondary actually to other chronic health conditions, such as chronic pain among medical cannabis patients that may assist in devising clinical interventions for this group. And we need more understanding regarding how well patients with high anxiety informed about anxiolytic properties of CBD and why they do not use CBD if CBD can help with anxiety. And generally, what cannabis products they prefer and use. And overall, we need more clinical trials, high quality clinical trials to study and treat high anxiety patients, because results do not suggest reductions in anxiety over time, despite the ongoing use of medical cannabis. But results also do not suggest deterioration in anxiety either. And this is, we would like just to express appreciation to Pennsylvania medical cannabis patients, our scientific advisory, community advisory boards, and our team. Thank you very much for your attention.
Thanks for that presentation, Janna and Katya. Those were some great information learned there, certainly on my end as well, too, both as a medical cannabis patient and working with our research team. Did want to circle back to some questions that I had for Katya's study as well as Janna's. I know that we had talked a little bit, and Katya, you had mentioned kind of the interesting finding that seemed that Pennsylvania patients were more likely to be looking for terpenes than they were for cannabinoids, and as well kind of acknowledging that certainly different with California. Was this something that was surprising to you? and kind of how did that unfold throughout the process of the study?
Yeah, I just think that it can be like a sort of a marketing point. So kind of the focus not on THC concentration so much as like in other states when cannabis products are being marketed, but it's mostly about like more stressing on the therapeutic part of it, not how high you can get from this, but how much relief you can get for like range of conditions. And I like know from patients from the qualitative interviews, like many of them like keep with them they like leaflet, like a flyer, like with the list of the major terpenes and how they might affect conditions. Like it's not clear like how those recommendations are based on the research, or it's some of them may be just anecdotal evidence, but still it's helpful to keep track of that. Yeah, it's surprising, but it's a less like I mentioned a lot in the like requirements in the policy, how it's being outlined that like there is a requirement to have a label like on the major terpene content for Pennsylvania medical products, so which is not the case for California, for instance. And in other states, they might still have major terpenes on the label, but it's not required by law. Again, it just can be a marketing point, how this product stands out to appeal customers.
Yeah, that definitely makes sense. Now, a question for Janna. Curious about how did you decide the cutoff between the high anxiety group versus the low anxiety group? I believe you called moderate versus mild.
The beauty is that I didn't. Was decided statistically. This is how like basically people were kind of divided into two categories by using this statistical modeling. But basically what we decided is kind of how many groups we need based on some statistical indicators, but this is how machine kind of divided people into these categories.
Great. Were there any analysis or consideration for the types of cannabis used by the high anxiety or low anxiety groups?
You mean what cannabis use, like products they prefer?
Yes.
Yeah, basically, I hope that after we did analysis by, for example, CBD use, we will see, like, ideally what I expected was that high anxiety group would have high probability of CBD use, and low anxiety group has like low probability. However, for some reason, I don't know, like as you saw, CBD was not very common and it reduced over time. And I don't know why, honestly. Maybe this is what patients see not very effective or something else. Maybe it's a matter of price or like lack of education. I'm not sure.
Yeah, it definitely makes sense. And I was certainly wondering the same thing about CBD as well. I think this kind of translates nicely into a question for both of you. What additional research would each of you like to see in relation to your specific study in the future to kind of help elucidate some more of these questions that have popped up from the research?
Yeah, in my case, obviously more objective measures and not just references, but what people actually using, just so it's more solid and convincing for research community. Maybe something like purchase data, which has some limitations in terms of like how product details are being entered in the database. It's not always consistent across different dispensaries and across time. So maybe in the future, some study looking at the primary strain used by patients and looking at the key, for instance, two top cannabinoids or terpenes and how they impact symptoms relief over time might be like more kind of maybe more like this was study like more of an exploratory character, you know, like just tap the areas where we can dig deeper, like, and the follow-up research can be more like of a kind of confirmatory in nature, like whether like indeed by using objectively measured data like purchased products, how they affect actually symptom relief, like let's say like 3 months later after using the product.
Yeah, it definitely makes sense. How about you, Janna? Is there any follow-up research that you would like to see?
You know what? I think when people are talking about like is cannabis effective for anxiety or not effective for anxiety, I think people who basically do not see it as anxiolytic agent, I think there is this kind of assumption that anti-anxiety medications like CCRIs or benzos, they're effective. They're kind of evidence-based. Yes, this is true. But I would love to see a clinical trial, like to have, you know, two groups of people who kind of manage anxiety with medications and cannabis, and people who manage anxiety with just medication, just to see how outcomes are differ, if outcomes differ or not. Because unfortunately, I think there is some kind of reason for people using cannabis in addition to medications or instead of medications.
Yeah, I definitely had a similar idea a while back. I think it was when we were kind of talking about the research design of the study in our team meetings. But I was thinking as well, even studies that also look at people who utilize talk therapy as well, and seeing
Yes.
that there might be some sort of aspect of it where treating the root cause of the anxiety through talk therapy while managing the symptoms of it with cannabis versus groups that don't, that could be an interesting pathway as well. So kind of fits well with what you said about kind of differences between SSRIs or combination between cannabis and SSRIs or benzodiazepines. So that definitely makes sense. For anyone else in the audience who has questions, feel free to pop them in the chat. I do have a few more here on my end, but feel free to drop them in and we'll get them in front of Katya and Janna. Definitely kind of saw a common theme throughout this, kind of with education, patient education, potentially even dispensary agent or physician or pharmacist education kind of popping up. What do you think these findings from each of your studies kind of speak to for the need for education for patients? Certainly know that we can't really draw anything or causality-wise from these, but I think it does give us some good information. What's your perspective?
Causality. Can you just repeat the question one more time?
Yeah. What do you think your findings from your study mean for kind of furthering patient education or general public education?
I think that at least in PA, as a leaf dispensary specifically, they, like I said, they do a really good job in educating patients like more deeply on specific compounds beyond just THC and CBD, like how they might affect their health conditions, and maybe by providing more kind of linking their statements to our specific studies, like, you know, providing more context on the, like, whether it's anecdotal evidence or it's based on the clinical trial, observational study. So, like, we know, like, how, like, strong the evidence is for specific claim for a specific terpene or cannabinoid. Yeah, but I think that still PA can be like an example, like a good setting point for other states in terms of like level of education and feedback dispensary agents provide to patients.
And how about you, Janna? Was there anything in particular related to education that popped out to you for your study?
Perhaps maybe more information about anxiolytic qualities of CBD, I guess. Yeah, but the problem is that evidence base is not like large, there are like only, again, few clinical trials. So I'm really not sure what else patients can be educated about other than CBD kind of properties.
Yeah, it certainly makes sense. We do have a question in the chat. What study results will assist with medical cannabis for being placed in employee benefits plans for companies? This might be a little bit kind of outside of the realm of the studies. Do you have, Katya or Janna, do you have any input on this? From my understanding, it's primarily based on randomized control trials that really show efficacy with specific dosages for insurance plans to really cover it. That will probably take a long time for those types of studies to come out, specifically due to the nature of how research access is limited by the federal government, with currently being in Schedule 1. Mainly because all of the plant-touching universities currently have to go through the DEA to utilize their cannabis for research. And that cannabis has been notoriously sub-quality and does not necessarily represent the quality at dispensaries. But certainly we can possibly put that. Do you have any input, Katya or Janna, on that?
I think it's a question for Lali. She's on the call, so maybe she will be a better person to answer this question.
So I did want to address one last question here from that I had. What are some of the difficulties of conducting this type of research? Is there any information that you wish you had access to, or any kind of unforeseen barriers? Just thinking about the future moving forward.
I think the first and foremost, it's difficult to do research with the like real world, like whole cannabis plant, because it has so many compounds, and it's really hard to measure like precisely, like even like products in dispensary, like consistency in the content, even if it's labeled the same. Like it's, yeah, like I think consistency and availability of the products will be the major difficulty in studying how like specific cannabis products affect health conditions, because like sometimes your choice is not dependent on what you want to buy, but just what is available. And so you might just get whatever like works for your budget at the time, and whatever like is more closely like similar to the products you used before. But consistency, this is the issue.
Yeah, it definitely makes sense in terms of some of what we've seen throughout our data as well too, with price being an issue as well. If anyone else has any questions, please feel free to put them in the chat. Otherwise, I have gone through my list on my end. Is there anything else, Katya or Janna, that you'd like to mention about your study?
I think, like when I think about like limitations of my research, and basically, I think there is certain like kind of level of what quantitative study can tell you. And I see like huge value in follow-up qualitative research. Like, okay, you have some picture, right? You see some people have high level of anxiety, some people low. Some people kind of use CBD, some people do not. But basically, I think there is a lot of value to follow up with qualitative interviews and even longitudinal qualitative observation, just to see, how people use cannabis, basically if there are any rules, any like regimens, especially that Pennsylvania kind of utilizes self-directed treatment, right? There is no like prescription, like how many times per day. So basically it would be very interesting to do this like ethnographic kind of follow-up study just to see what's really going on.
Yeah, it's definitely a good point to make, and kind of I think even harkens back to the previous question about kind of what will it take to get more research for kind of insurance to get involved as well too, is that having a full picture of dosing, of how many times a day you need to be using, of all of that information that is really going to help inform and educate doctors moving forward is certainly an important aspect. And also with qualitative research as well too, kind of taking the anecdotal research that or anecdotal information that people so often hear just kind of talking to friends through word of mouth, and kind of putting that in a more measurable form like qualitative research definitely can give us a more detailed explanation without having researchers to kind of jump to their own conclusions based on what the numbers are telling them. So definitely a good point to make. Did want to say thank you to both you, Janna and Katya. Definitely some great presentations and definitely great research coming out that'll help us build towards the future and additional studies moving forward. We'd like to thank the team as well, Dr. Lankenau, our center director, who's on the call, and all of the patients who put in work on this. And certainly big thanks to Jay and Lolly, who are on the call from the Department of Health. Thank you for all you do to help make our jobs easier as well as researchers.
Thank you.